Well, hello. We are live. It's about 4:35. We have Dr. Estraveta here. We're talking about venous disease. Last video we did about the arterial disease had some good responses from there. So we're going to work on the other part of the vascular system, the venous disease. Venous, varicose vein, big, heavy legs. That's what patients come in and talk to us about. I have my legs feel heavy, and I have these varicose veins. What can I do about them? They look ugly. Besides them looking ugly, what are the I will say, what are the medical problems that can happen?
Sure. For those of you who didn't join us last time, let me just back up just a little bit, Dr. Lamb. So just to bring us all to the same page here, let's talk about the difference between arteries and veins. So arteries are what takes the clean oxygenated blood from your heart to your toes, your fingertips, and your brain. Veins are what brings it back to your heart to get cleaned up, reoxygenated, and sent back out. So veins are always working against gravity. So because it's working against gravity, it has valves that open and close, and that's how the blood gets back to the heart. All right, now that we're all on the same page, I'm going to employ my Vanna White here to show you a nice little teaching diagram that I really like about venous disease. So venous disease, this shows very well. I don't know how well you can see it. Kind of shows the sequelae of how varicose veins or veins that are not working correctly, what happens. So it starts like this with varicose veins, those large bulging varicosities. Some people, they may say that they give them kind of a throbbing or a burning like pain. Some people describe it as restless leg syndrome at night. And other people may have no symptoms at all, other than the fact they just don't like how they look.
This is what we see when they come in. We see this pigmentation or hyperpigmentation right here. That's what we see when they come into a podiatrist's office, working in reverse right here. So we see the discoloration. They always say, Doc, can you get rid of that brown discoloration?
Well, unfortunately, usually by the point that it gets to the discoloration of the skin, that's something that's permanent. Treating the issue itself and decreasing the swelling can improve the symptoms, but usually pretty minimally as far as the discoloration of the skin. It's usually more of a permanent thing.
So before it becomes that color that we see here, we want to take care of this problem. That's the valve that Dr. Estraveta was talking about. Blood goes up, the valve closes. If it doesn't close, then it leaks backwards. That's where you get this big bulging vein. So remember this picture? That's what we're talking about, the venous disease, the veins. This is a good valve. That's a bad valve. The gate is not closing, so it's backflowing. The gravity pushes down. That's why we see that a lot in the legs, as you can see. Now, the complication that we see, besides the discoloration, it's also ulcerations.
Mm-hmm.
We see ulcerations, get consults for taking care of these wounds, which, luckily they're fairly easily treated with compression.
Absolutely. So compression is the mainstay of treatment, as well as keeping these wounds clean. They can get infected, which is why good wound care is essential. As far as treating the varicose veins really help heal the ulcers? Actually, no, it doesn't. The mainstay in the whole approach to how we heal these wounds and get the patients back to having completely closed skin is through compression, keeping the wounds clean, and also some debridement and wound care modalities. Once the wounds are healed, to prevent them from recurring or occurring in another location is why we treat the varicose veins. So varicose veins that we most routinely treat are in the superficial system. So as you know, there's two types of vein systems. There's the deep vein system and the superficial system.
Yes.
The superficial system drains into the deep system, which is why the more superficial veins are where you see your varicose veins bulging out, because they're more superficial, so closer to the surface. And as far as the treatment, there's a number of different things that we can do. In the old days, you might have heard of patients getting vein stripping. definitely not the standard of care today. We know that patients that have had vein stripping in the past have other problems that they present with down the road, and oftentimes they have recurrent varicose veins.
Now, if they stripped that vein in the past, now I know we use that vein for cardiac bypass.
Mm-hmm.
Would the varicose vein be useful for cardiac bypass or no?
No, for cardiac bypass, we do not use varicose veins, because you need, for cardiac bypass surgery, you need to have a vessel that is normal sized and normal functioning in order to serve as that additional highway bypass around the blockage in the heart. If the vein is varicose, then the vein is very stretched out and is not going to be able to carry the blood volume in the same way that it is needed.
So I guess the conclusion is, if it's a varicose vein, it's not functioning properly to carry blood back up to your heart, it's not a good vein, not a good vessel for bypass. So it's really good for nothing there.
Yeah, pretty much. So we oftentimes see patients that have had cardiac bypass surgery, and when they do the bypass surgery, they usually harvest the vein below the knee if it's big enough. And just because you've had your vein harvested for bypass surgery doesn't mean you can't have that vein be varicose. They don't always take the vein in its entirety. Sometimes they'll just take the portion below the knee, leaving the portion above the knee to the groin, which can become varicose and also have other branching varicosities off of that vein.
No, a fun factoid that in podiatry school we used to pimp our students and residents in. What is the most common cause of bilateral tarsal tunnel syndrome? That's the question that we usually ask our residents or students. And believe it or not, it has nothing to do with podiatry. It's varicose veins. If a patient has bilateral tarsal tunnel syndrome with positive Tinel sign in the tarsal tunnel, a lot of time it's varicose veins that causes that. So that's a little connection there between podiatry and vascular surgery. So if you get this Tinel sign, like sort of neuropathic symptoms in these patients with varicose veins, sometimes it could be tarsal tunnel syndrome, entrapment of the tibial nerve.
All right, I learned something new today. Wow, fantastic. So another connection between podiatry and vascular surgery on the venous side is a lot of the patients we see have combined venous and arterial insufficiency. So they might not be getting the best blood flow down to their feet, but then in addition to that, they have the ischemia from the lack of arterial flow, but then they also have the swelling, which compounds the problem because they also have venous insufficiency.
Yeah, those patients are pretty hard to treat on our end, right? Because you have this venous thing you want to compress to get it to heal, but then now you have an arterial problem that you compress too much, then you're not going to get enough blood flow there.
Exactly. And some patients present like they have venous insufficiency, but they actually have heart failure. And sometimes they can just have too much fluid that their heart isn't able to pump the volume in order to get some of that water off. So they can also present in a similar way.
So it's a teamwork. Vascular surgeon, podiatrists, and primary care doctors, and cardiologists, and possibly even nephrologists to get the kidneys going.
That's right. That's right.
So good teamwork. So we have some toys here today for the endovenous intervention. We talked about endovascular intervention last time for the vascular disease. Now we're talking about venous disease.
Yes.
We no longer strip the vein with the big ugly scars now. Now there are great advances. I remember when I went to a course, they were talking about laser ablation, radio frequency, talking about shrink wrapping. So what is new this time?
Wow. All right. Well, I'm just going to start. So there's 3 basic modalities that we use today to treat venous insufficiency and varicose veins in the superficial system. One way is a laser ablation, which actually uses laser energy to transmit the heat to close down the vein. That I do not have I do not have a little toy to show you because I don't do any laser ablations. The next option is this catheter right here. This is a radio frequency ablation catheter. And what this does is this emits radio frequency and that generates the heat, which goes on to close the vein.
Right. Yeah. Radio frequency. Yes.
And so this gets up to 120 degrees Celsius.
Wow.
If you think about it, that's pretty darn hot.
Yes.
So nerves and veins run together anatomically. So with these heat treatments, we always have to be cognizant of the fact that we can cause a nerve injury. And some of these nerve injuries, they recover with time. Others of them, these patients are miserable for a very long time, and sometimes it's lifelong.
That is, no, I've heard that complaint from some patients. Oh, I just had this laser procedure. I hear more about it with the laser for some odd reason than the radio frequency, but the laser, I guess, is it hotter or is it more prone to getting that complication?
Yeah, it's more prone just because of the type of energy that it uses. When we place the laser catheter or the radio frequency catheter inside the vein under ultrasound guidance, we use tumescence, which is, it includes a local anesthetic as well as fluid to surround the catheter inside the vein and to isolate it from the nerve, thereby protecting the nerve. Despite doing this, patients can still have nerve injury, which aside from the nerve injury with this, patients are normally receive somewhere between 10 to 20 pokes with a needle in order to instill this tumescence to do the procedure safely. So that is a definite downside. And this also, the patients are also at risk for a DVT.
Yeah, that can go on to a pulmonary embolism. That is deadly. That can kill you. So.
Yeah, I wish that I could tell you that there was any procedure either one of us did that had no risk whatsoever.
No, anything that we do.
Everything has some risk.
Yes.
And then now I have the latest and the greatest technology, and give this back to Vanna here. This is called VenaSeal, and VenaSeal, it's the only treatment like this on the market. And what it is it is a cyanoacrylate, which is it's an adhesive that is instilled within the vein, and then the vein closes off. And benefits of this are the fact that there's no heat, so there's no risk of nerve injury, and there's only one poke for the patient, local anesthetic injection, and then getting access to the vein. And so that's only one poke as opposed to several pokes. It's a pretty nifty system. You can see here that's all of it together. Just to kind of give you a little bit of background on how it works, I have one here to show you. So we get access to the vein, and then we place this wire inside the vein, and then over that wire, nice. And you can see it has a nice soft tip, so because veins you can perforate easily, and then over that wire you place this catheter. Here, you can be my demo guy.
There you go.
Dr. Kevin Lamb, he's now endovascularly certified.
That's right. Let's see if I can get this in right. So
doing good. Right.
That little curve is causing a little stoppage. Right
Otherwise, we'll just go a little backwards here.
Okay. There you go. Leave it to the experts. There you go.
All right. So this catheter is threaded over the wire. And then when we get in the right place in the vein, which we see under ultrasound guidance, and you can also see there's like markings on the vein. So we can mark the distance. Then when Kevin's got it in the right spot, Dr. Lamb's got it in the right spot, he's going to pull all this out.
Pull all this out.
And this guy stays in there. That's our guide.
Gotcha. This is the guide. The wire comes. The wire is just to help us guide to get in there. So it's all out.
All right, the next thing we're going to do, so this is our gun that helps us drop the glue.
Okay.
So we will drop the glue.
This is in your veins right now.
And then we're going to place the syringe inside the gun. And then we will, you can see the plunger moving forward. Then we will place this in this special catheter and put this catheter inside that catheter.
Inside the catheter that's already in the vein.
Yep. And you're going to thread it in there. We are closing veins left and right here in Naples. This is fantastic. All right.
So it solves a couple of different problems. The feeling of heavy leg, swollen legs a lot of times. So those are common complaints that we see, what we hear about. So I'm all the way in there now.
All right.
So we're all the way
There
to
it
the
goes,
end.
sticking out the end. And
Uh-huh.
then we're gonna put this to this, and we're going to marry them. And now we have our little guy. And so now what we're going to do is, so every three seconds we hold our gun and we go 1, 2, 3. And we're going to pull this back and compress it. And initially our first compression will be 3 minutes, and that kind of creates the hard plug that all the other glue will stack up against.
Okay.
And then every 3 centimeters that we pull back after that, we hold for 30 seconds. So most procedures take less than 10 minutes.
Okay.
Another advantage of this procedure is that you don't have to wear compression stockings because of the fact that you're filling the lumen with this adhesive.
So pretty much like an endovascular glue.
Correct.
You're putting, and you put compression on it. And what happens to that vein after that glue dries?
It just becomes scarred up and sclerotic and just becomes part of just the tissue.
Okay.
And it's very similar. I don't know how familiar everyone out there is with Dermabond, or the skin glue that surgeons sometimes will put on.
Dr. Chapman's grandma, she's a great fan. Hi, Peggy. And Dr. Mark Katz has joined us.
All right.
Beautiful.
So the skin glue, Dermabond, this is a very similar substance to that.
Dermabond, aka what they put on your scalp when you break your head and you go to the emergency room.
Yes, exactly.
That's what we know it as. The glue that sticks the skin together. So cool. So this is awesome. So after you put this Dermabond inside, or similar type of glue inside, you compress 3 minutes, 30 seconds all the way down, every 3 centimeters. Does this go into the perforators? Would this go into perforators?
So I will tell you, it is not FDA approved for perforators.
Okay.
But Dr. Scanlon and I, my partner, we do treat perforators with that. The only FDA approved treatment for perforators is actually radiofrequency ablation.
Gotcha.
But you can do this very nicely and very easily for a perforator, and it is covered by insurance.
Now, for those who are not in the medical field, perforators are the connection between the superficial, the veins on the surface, to the deep system, which are almost underneath the muscle. We usually don't worry about the deep system because they have that pump, the muscular pump. Am I correct? So we rarely see you guys treat that,
right?
If ever. But mostly you're treating superficial or the perforators.
Correct.
Most likely the superficial. That is what you see when you go walking with varicose veins or have that bulging thing in the thigh. And the picture in the brochure shows a thigh one. When you're wearing a bikini during the summer, you see that big bulge out there. That's varicose vein, guys. So cool. This is awesome. No heat.
No heat. One stick. That's it.
One stick. And it's very atraumatic. I'm looking at this. It's very atraumatic. Very.
It's a floppy catheter.
Yeah, floppy wire catheter.
And most patients, they don't have any real complaints during the procedure. It's very fast, and there's no downtime.
It's like my gawking gun, but very accurate. That's what it looks like. A very accurate gawk.
Ah.
So cool. This is awesome. This is great for now. Do patients need to have compression therapy before they qualify for this under Medicare and insurance?
Yes, so still 3 months of conservative management before it's covered by Medicare. But for the most part, by the time patients are referred to a vascular surgeon, they've worn compression stockings or they've used the compression pumps on their legs or elevation.
Okay. Cool. Yeah. So, when patients come to me with venous disease, obviously I start the compression therapy and refer out to the vascular surgeon so they could do their magic. And sometimes when I also see them is first time when I see them are when they have those venous ulcerations, which are different from arterial ulcerations. So we treat them with that. Now that's a different topic. We treat it with things called Apligraph or a collagen powder nowadays. So a lot of stuff we can do in the office, such as this is done in the office now, which is great because back in the day the stripping is done in the hospital or
Right.
control bleeding. You could bleed out. This stuff you can't.
Right.
Pretty much this catheter you cannot bleed out. It could be done in the office. One stick, no nerve damage, right? And the chance of perforating with that flimsy wire is pretty thin.
Yeah, it's a real soft, very soft tipped wire.
Awesome. Now, what is the 1 year follow up about with this 1 or 2 year follow up?
So this came out initially to the market in 2016, and we've had great outcomes with this. As far as the veins reopening, it's actually better than the radio frequency.
Okay.
And so after the procedure, you come in 30 days afterwards and you get an ultrasound. So we make sure that whatever was supposed to be closed is closed, and that the even very low risk of having a blood clot, we make sure that there isn't any clot.
Okay. Do people get this done for cosmetic reasons, or is it only for medical reasons what they have complaints?
Some people have it done for cosmetic reasons. But usually when you ask a patient further questions, they realize that really they do have some symptoms from it. Usually if your veins are so varicose that you're noticing it, usually you do have some symptoms that perhaps you're overlooking.
Well, let's say besides the physical appearance of varicose vein, what would you say are most common symptoms that patient will feel that they may not associate it with varicose vein, but they are most likely associated to their varicose veins?
People will describe it as being a throbbing like pain or a feeling where their legs get very tired at the end of the day from standing. They feel that their legs are swollen. Some people, the actual varicosity itself will be very tender to the touch. Other people will describe it as a kind of like a restless leg or creepy crawly kind of feeling at night when they're in bed.
And you guys do the specialized ultrasound exam with the venous system when we send the patient over to you guys for consults, am I correct?
Right. There's two types of ultrasounds that you do for the venous system. One is looking for DVT or a deep venous thrombosis, which is a blood clot. And the other is venous insufficiency study, which that actually looks at how the valves open and close and how the vein is functioning itself. The venous insufficiency study is done with the patient either sitting upright or standing, because we need to have gravity in order to help us assess how that vein is functioning.
Awesome. Well, guys, if you have any of those symptoms, see your vascular surgeon, or you see a podiatrist first. We can get you to your vascular surgeon. But those are the common symptoms, huh?
Yeah, and one thing I just want to pass along is that if you do have wounds, it's very important that you get them treated, and that even though it's a weekly trip to a wound care center like we have here with Dr. Lamb and his colleagues, it's really important that you do that and keep that wound clean and get it healed. It's a real nuisance, but it's important that you get it healed, and then we can make sure that it doesn't come back again by treating your venous insufficiency.
Yes, all of our offices can treat wounds. We treat wounds at all our offices with specialized grafts and different modalities and surgical debridements. All our offices are capable of doing that. And a lot more treatments are done outpatient now because of cost. Everyone talking about cost.
And the patient, you don't have to get admitted to the hospital. And we all know that going to the hospital is scary to everyone,
It is
us
scary.
included.
Exactly right. Exactly.
We would much rather do things in our office than go to the hospital.
Less chance of infection. You know, we all hear about this MRSA infection, right? So less chance of MRSA or less chance of C. diff, catching C. diff and MRSA. These are both infections that are very common in hospital settings. Not because they're dirty, it's just because you have a lot of patients that are sick that are there. So great. Dr. Estravada, thank you for joining me again.
Thanks for having me.
Love this.
Like what are some other topics out there that you guys want to hear us talk about from the toe and flow perspective?
Let us know, guys. Students, residents, even our patients out there. Go ahead. Send us some questions. We'll try to address it at our next Facebook Live, guys. Okay? Have a good one, guys.
All right. Bye.